Anand is still busy with the transplant. He's still doing the biliary anastomosis. So one of my final year postgraduates, Dr. Harshil, will be making the presentation.
Good evening. Thank you, Kapoor sir. Myself, Dr. Harshil Shah. I'm third year MCH in Mahatma Gandhi Hospital. Anand sir is busy, so I'll be presenting on behalf of him. So, starting with the introduction, as we all know, approximately 5% of all trauma admissions are included. It includes liver injury. And liver is the most common solid organ involved in blunt abdominal trauma, and it is the second most common in penetrating trauma. The most common etiology being motor vehicle accidents, and other etiology, it can be collision with car, falls, or motorcycle crashes, and penetrating injuries. Isolated liver injury is seen in less than 50% of blunt abdominal traumas. It is always or majority of time associated with other injuries like splenic injuries and rib fractures and other organ injuries. And liver injury is the primary cause of death in severe abdominal trauma and has a 10 to 15% mortality rate. Why liver is so commonly injured in this blunt and penetrating abdominal injuries? The reason is its vulnerability because of its large size, its position in the anterior portion of the abdomen, and it gets crushed between the bony structures, anteriorly ribs and posteriorly vertebral columns. And it is a fragile parenchyma as well as thin Gleason capsule. And the vessels, hepatic veins and portal vein and artery, they have thin walled and susceptible for post-traumatic bleed. Coming to right lobe versus left lobe. As we all know, right lobe is the major area, so it gets involved in 80% of the cases. And in that also the posterior segment due to its size and proximity to the ribs. And left lobe injuries are uncommon, but if present, they are majority associated with lesions of the pancreas, heart, duodenum, and transverse column. Coming to today's topic, grading. So before grading, what type of liver injury can be associated? It can be parenchymal injuries, subcapsular hematomas, laceration, contusions, hepatic vascular disruption, as well as associated biliary injuries. And why the grading system is required? As in any other solid organ, it decides the management. Over the decade, the management, as discussed also, is shifted from operative to more of non-operative management. So the grading system helps on deciding whether to go for an operative management or a non-operative. It also prognosticates the injury and predicts the mortality as well as morbidity. And it has also importance in medico-legal aspect. Coming to the grading system available, it has started with CT imaging criteria in 1989. We'll discuss it in the Journal of Radiology, followed by widely accepted and used American Association of Surgery of Trauma classification that majority of us are following. It also includes operative criteria and pathology criteria based beside the imaging criteria, and followed by we'll discuss about the World Society of Emergency Surgery, that is WSES 2020 classification. This is the first proposed classification of liver injury based on CT scan, which was published in Journal of Radiology in 1989, which has been included by the American Association also, which will be discussed in the further slides. So they have started with capsular avulsion and lacerations and graded it based on the severity. This is the first liver injury grading as per the American Association. It includes hematoma and laceration. We will be discussing. This is just an overview. And in this classification, the vascular injury is basically defined as a pseudoaneurysm or a AV fistula, which appears as a focal collection of vascular contrast that decreases in attenuation with delayed imaging. And any active bleeding from vascular injury can present as vascular contrast leak or focal or diffuse. It can be focal or diffuse, and that increases in size or attenuation in delayed phases. Vascular thrombosis can also present, which can lead to organ infarction followed by in trauma. What is the grading system if more than one liver injury is present? So WST has defined it as grade should be based on the highest assessment, either made on imaging or during laparotomy or operation or after pathological specimen. If more than one grade of injury is present, it can must be classified as highest grade of injury. And we can advance this grade up to grade 3 if more than multiple injuries are present. So as per current 2000 18 criteria. The first grade on basis of imaging, it is subcapsular hematoma less than 10% of the surface area, or parenchymal laceration which is less than 1 centimeter in the depth. And after that, grade 2 is subcapsular hematoma 10 to 50% of area with intraparenchymal hematoma which is less than 10 centimeter, and laceration which is 1 to 3 centimeter in depth and less than 10 centimeter in length. So this is the imaging and illustration. So as we can see, so here is the subcapsular hematoma described here, which is according to grade 1, and a small superficial parenchymal hematoma less than 10% of the surface area, and same with more than 10% less than 50% is grade 2 subcapsular hematoma without any vascular or more than less than 3 centimeter of the depth. This is also grade 2 injury, as we can see parenchymal contusion and a subcapsular hematoma which is visible in this. Coming to grade 3 severity on imaging criteria, any subcapsular hematoma which is more than 50% of the surface area, or ruptured subcapsular or parenchymal hematoma. Once it ruptures, it becomes grade 3. Intraparenchymal laceration which is more than 10 centimeter in length and greater than 3 centimeter in depth. And any injury in presence of a liver vascular injury or active bleeding, but it should be contained within the liver parenchyma. If that vascular injury is contained within the liver parenchyma, it is grade 3. So as we can see, it is more than 50% and the laceration, it is more than 3 centimeter in depth. So it becomes grade 3 liver injury according to the American Association. Coming to the grade 4 and grade 5. So any parenchymal disruption involving 25 to 75% of hepatic lobe or active bleeding which is not confined to liver, it is beyond the liver parenchyma into the peritoneum, is grade 4. And parenchymal disruption more than 75% of hepatic lobe or associated juxtahepatic venous injury which includes retrohepatic vena cava and central major hepatic veins are included in grade 5. So as we can see, there is hepatic venous disruption here with subcapsular hematoma also, but it is less than 50%, so it's in grade 4, followed by the here also subclotted capsular blood and hematoma with avulsion. And grade 5 injury, it includes more than 50% of parenchymal involvement. So this is just a summary of grade 1 to 5 of American Association. As we have discussed, it's a beautiful picture available online. So it summarizes all the grades of starting from grade 1 to grade 5, which is major hepatic lobe disruption and vascular injury. So this is anatomically based. So as now coming to the next question, is the anatomical description of liver lesion is enough? So yes, definitely this management algorithm is followed everywhere, but it is not the definitive one because there is no correlation between these grades and a physiological state of the patient. So in American Association grading, the physiology is not included. To determine the optimal treatment strategy, it should be supplemented by hemodynamic status and associated injuries, which is well included by World Society of Emergency Surgery classification. So we'll move forward to WSES 2020 guidelines, which has divided this liver injury into 3 classes, that is minor, moderate, and severe. In minor, there is 1 grade, grade 1. In moderate, 2 grade, and severe injury are divided into 2 more grades, grade 3 and grade 4. In hemodynamic stability, what they have included is ATLS definition of unstable patient, which include blood pressure of less than 90 and heart rate of systolic blood pressure of less than 90 and heart rate of more than 120, with evidence of skin vasoconstriction, that is cool calmi, and decreased capillary refilling in the peripheries, and altered level of consciousness and or shortness of breath. So in WSES, whenever we are staying patient in unstable, this criteria should be followed, which are defined by ATLS. In first grade, they have included American Association grade 1 and 2 with hemodynamic stability. So basically WSES minor, major both include stable patients and the anatomy is same as of American Association grading. The only difference is the grade 4. In WSES grade 4, which is severe injury, they have included any injury from grade 1 to 5, but with hemodynamically unstable patient, either blunt or penetrating lesion. So they have included this physiology in the classification, and this is the guidelines. And sorry, I have not included many things. I'm a bit unprepared, Kapoor sir. I'm sorry for that, but thank you.
So thank you, Dr. Ashish. You said
Harshil.
Harshal. Okay. So your talk was grading only, so it's all very theoretical, and that's why you have tried to made the pictures and all, and it's justified. No need to say sorry, because the next speaker is Dr. Jayant, and he is going to talk about your management. So he will try to, then we will understand how these gradings, they are basic principles, how is followed, and how it helps in the management of the patient. So that's why I don't think it's anything, because these are the gradings available. So you would only tell the gradings. And so here is the role of Dr. Jayant, who will take the further. So I think, sir, comments we can take later, because this topic is
Yes.
same.
Yes.
Thank you, sir.